Estamos escuchando el vídeo de los aplausos ahora.
Welcome to EPIDEMIXS TV. Thank you very much for being together here again with us. And today it's a special day because we are launching the first chapter in English. So I would like to thank all our colleagues and persons who are helping us to build this wonderful program. And today we would like to talk about Africa and the possibilities to support and to collaborate with the countries that are now starting to suffer the pandemic also in this continent. I would like to introduce you very quickly to all participants that will be talking from Mozambique, Sierra Leone, and also other Africans or people who are working with Africans that will talk about Zimbabwe, Mozambique. Again, we have the researcher of IS Global, Kiki Basat, to talk about many research fields that are going on. And we have also somebody from Nigeria. We have a good colleague from Mozambique, Eduardo Celades, which I will introduce you briefly. We have Marta Lado from Sierra Leone. We have Kiki Basat, as I told you before, from IS Global. We have Ibrahim Mohamed from Nigeria. And we have Juan Burgos, who will speak about Zimbabwe. Thank you very much. And let's just listen and look at a wonderful video to raise spirits.
There is a word that is Ubuntu. A word that captures the essence of human relationships. Ubuntu means that we are all united. It is a way that is invisible to the eyes, meaning we are all allies. It's trusting and collaborating, supporting and sharing our essence. Lots of small people in small places doing small things can change the world.
Ubuntu is the sign of unity, and we need to be united more than ever to help each other, as you could see in the video. And this video was developed by Senfic, our Spanish partner of family medicine, and we are very thankful to them to allow us to share and distribute the video. We would like to start this wonderful chapter about Africa with Eduardo Celades. Eduardo is a good friend that I met in Geneva. He was working in WHO, has a lot of experience in many UN institutions, and right now it's working in UNFPA. I would like him to explain us the situation about Mozambique. Eduardo, good afternoon.
Good afternoon, Jordi. And first of all, thank you very much for inviting me to be here today. And as well, congratulations for this great initiative. I think it's very much needed. I'm going, more than talking about what's happening in Mozambique, you told me that I have like 3 minutes to do my first speech. So I want to pass like 3 messages, maybe to the audience and to the people that they are listening to us today. Here in Mozambique, we had the first case 2 weeks ago. Now we have only 10 cases. So let's say we are like about 6-8 weeks behind what is happening now in Spain. But I have 3 main messages that I would like to pass. The first one is that we need to be ready for the worst case scenario. The second one would be that we need support, and we need like your support and support from other countries. And the third one is that we need to do this together. And I will explain these 3 messages that I had. The first one is like, despite the epidemic is starting here, and despite that there are many things that we don't know, like what's going to happen in a warm country, or what's going to happen in a country with many young people, like 65% of the population is young, or what's going to happen in a country that we did an early lockdown. So we are taking the appropriate measures very early. But however, here in Mozambique, we have more than 1 million people with HIV. This is the 3rd country in the world with more incidence of TB. We have like a lot of malaria cases. We have malnutrition. 42% of children under 5 are standing. They have standing. So we need to be ready for the worst case scenario. The second message is like, we need some support. If a country like Spain or Italy or now the US, they are struggling to fight this epidemic, what's going to happen to a country like Mozambique? We have only 22 ventilators in the country. We have like less than 500 beds, isolation beds. We have only 6,000 nurses, a very weak health system. So there's a lot of willingness to fight, and people are already working 24/7, people at the Ministry of Health. But we can do this alone. And this is my third message. It's not going only to be getting resources from overseas, because we don't need money now. I mean, the global supply chains are broken. We cannot get personal protection equipment in other countries. There are not. We cannot get tests. Nobody's selling SARS-CoV-2 tests. So what we need is like to work together with people from other countries to mobilize these resources that they are already there. I mean, I'm just thinking in what's going to happen with IFEMA once it's closed. Maybe it can come to Mozambique. What's going to happen to all these tests and PPE that hopefully in a few weeks they will not be needed in Spain or Italy or the US. Maybe we'll need them here. So these are my 3 messages that I have to start. And I will be happy to discuss them during the session today, and to see how we can work together to try to prevent and respond to COVID in Africa, and especially in Mozambique. Thank you, Jordi.
Thank you very much, Eduardo, for the 3 clear messages to the point, and that's a good starting point. Right now, we would like to introduce Marta Lado. Marta Lado has been working many years in West Africa, and she was fighting Ebola, and she was one of the persons who had to treat more Ebola patients in the world. So I think she has a wonderful background to explain us what these countries are doing about this new outbreak. Thank you, Marta.
Well, thank you very much for giving me the opportunity to be here with all of you. I think this is a extremely privilege for me. I've been, as you said before, I've been living in Sierra Leone for almost 7 years, and we went through Ebola, and we thought that we were quite ready for any kind of epidemic that we could have afterwards. But what we are realizing right now is that we still don't have like a healthcare system that is strong enough to allow us to feel that we can control even now the small number of cases that we have. No? So Sierra Leone from the beginning tried to make like a planning, thinking of closing borders, trying to restrict people from countries that they were having cases. So then we will be able to isolate ourselves from the rest of the world and trying to avoid that kind of entrance. So the president of Sierra Leone, for example, closed the border like closed the airport on the 22nd of March. Everyone has been coming into the country in the last week before the closure of the airport was put on quarantine for 2 weeks. Also, the borders with Guinea and Liberia were closed also. So in the last weeks until this week, we have only tested 26 people so far in the population. No? We have 4 labs because that's one of the inheritance that we have from Ebola. We were able to do molecular testing, and we have machines, and we had capacity in lab technicians to be able to test people, at least with the real-time PCR. But we had like a very, very small storage of test kits to be able to start testing. So we were selecting specific people, but we were not even assuming the possibility of having already coronavirus in the population. No, and we thought that closing borders, putting people in quarantine that were coming from these affected countries was going to be enough. Right now, we declare our first case on Monday, second case on Wednesday, and today we already have 6 cases. But we have like a circle of almost 500 close contacts that have been interacting directly with this one. So we are expecting that probably in the next week, we're going to start multiplying our cases more and more. So in relation to what Eduardo was saying, I think that the main concern that we have in terms of the government and preparedness is that we don't have a healthcare system that is able to absorb another outbreak or another epidemic like Ebola, and even worse in this with coronavirus, mainly for the number of cases we are talking about. We in Sierra Leone, we only have 4 ventilators, but we only have 1 intensivist, 1 ICU doctor for all the country. Apart from probably 15 anesthetic nurses that are able to do some kind of ventilation or intubation if it's needed. But apart from that, we have been able to expand to 7 labs right now, being able to do PCR, but we only have 20,000 test kits so far. And because of all the restrictions in the bordering countries and in Europe and US right now, it's extremely, extremely difficult to get anything in the country, like test kits, but also personal protective equipment, drugs, medications. Most of our hospitals have like 1 single room for isolating cases, but that would only allow us if our number of cases all over the country is around 100. But what happens if we get to the magnitude that we are having in Europe and US, no? Apart from that, now we have decided to do some small lockdown for 3 days, just try to sensitize the population about like the contacts and about like how the way this disease is transmitted, try to mitigate some fake news and false ideas of relating this to Ebola. But the reality is that if we start having cases in an exponential way, like it has happened in all the countries from China to Europe and now to US, we will not be able to maintain our healthcare system that is extremely weak, because people already right now see that the healthcare system, the hospitals, the healthcare centers, they don't have even supplies enough to treat our main endemic things like malaria, tuberculosis, HIV, parasites, the infections that are like pneumonias, diarrheas, etc. So our biggest fear right now is that if we don't get these supplies, if we cannot protect our healthcare system and our healthcare workers, people are going to stop trusting the system, and we are not going to be able to get people to the facilities. In the last week, 50% of the hospitals were empty right now of patients. And it's not because people are not sick, because people are scared. They remember Ebola. They remember how many people die and how many healthcare workers were infected and how many people got isolated in facilities thinking that it was Ebola and dying for things that were not Ebola because you were in an Ebola time. So we are starting to see that the calls to the ambulance system in the country has been recording 50% of calls for pregnant women who were delivering and needing to go to healthcare facility for labor. Just reminding everyone that Sierra Leone is one of the African countries with the highest mortality during labor and postnatal, and 1 out of 17 women die normally during delivering or in the postnatal time because of hemorrhage, sepsis, etc. So 1 out of 17 women die normally delivering in this country. Imagine if the healthcare system collapses, what are we gonna get, no? So I would like to support the same ideas that Eduardo was bringing. Like, let's put ourselves in the worst case scenario when we have the scenario 4 of WHO of community transmission where everything and everyone could be infectious and transmitted the disease. Let's try to get as much support as we can from our neighboring countries and also brothers and sisters from Europe, US, and Asia. And mainly when they are running out of the outbreak and the epidemic themselves. And let's try to be all the African countries together in terms of setting up guidelines, creating protocols. There is so much information that is coming right now that is not approved and everything, that everybody's going crazy trying to find hydroxychloroquine, and the other one Kaletra, and the other one ivermectin, and the other one the other medication. And we don't have capacity of buying those drugs and supplying those drugs. So we need to get together to be able to do some multicentral, probably clinical trial that we can get drugs and support from outside, so then we can implement this treatment for the severe cases. So we are extremely concerned, despite having put many measures in place to prevent coronavirus to get inside the country. Now, at least Sierra Leone, we have 6 cases, but we are in the situation that Guinea was like 1 week ago, and Guinea today, Guinea-Conakry has 111 cases in just 1 week. So we are looking at that mirror and we are seeing that we need more and more support and getting united all together to try to prevent, to get to the worst scenario, which is the scenario 4, where the community transmission would make our systems collapse completely. People cannot do a lockdown like we have in Europe or we have in other Asian countries. People make money on a daily basis. If we have to ask people to stay at home, that means that everybody's gonna starve, everybody's gonna die with a lot of diseases at home, and all the healthcare system is gonna collapse again.
Thank you. Thank you, Marta, for this full vision of the problem. And thank you for talking about the restrictions, the biggest problem even of all the other disease that then people don't have into account. We'll talk about also with Kike Basat. Kike is the researcher of IS Global, the Institute of Global Health of Barcelona. And Kike has a lot of experience also in Mozambique. And he would like to explain us a little bit what IS Global is doing, is gonna do, and talk about these different researches. Kike, thank you very much. Thank you for coming.
Thank you, Jordi, and hello, everybody. I need to start by saying that I'm a bit jealous of Eduardo, who is in Mozambique and I am not. And I would like to be there. And of course, I'm locked in Barcelona and with no possibility of traveling there at the moment. I'm going to try and bring a little bit the perspective of our research center. We have been collaborating with the Manisa Health Research Center, what we call CISM, from its inception back in the year 1996. This is a research center of excellence, not only in Mozambique, but in Africa. And at this particular moment, it's the moment where we need to roll our sleeves and be there and help the Ministry of Health and help generating the knowledge that is capable of bringing some answers to the many questions and some solutions to the many problems. And to me, one of the big initial questions is, what is the true burden? In a context where you cannot test because you have a lack of tests, as Marta was very well explaining, and similarly to what happened at the beginning of the problem in Western countries, you have truly you underestimate the real number of cases that you have. We know in Mozambique, which borders with South Africa, that we only have 10 cases so far. But this is truly the tip of the iceberg. I'm really sure that in-country transmission is going on. We've had 25,000 Mozambicans returning in the same day from South Africa, a country that has thousands of cases next door. So there is no reason to believe that we are controlling well what is happening in the country. On the contrary, what I think is that we have no clue what is really going on. So one of our responsibilities as a research institution is to try to understand what is the true burden. And that should include community surveys. And I know this is not the best moment to do this, and there are other priorities, but this is the kind of thing we can do in parallel to what the Minister of Health is doing, and that would allow us to estimate more reasonably what is going on. The second big question is what is the behavior of this virus in a very different context to what it has seen in the past. In the last 3 months, we've seen descriptions that the virus is relatively benign in children, and of course very aggressive in the elderly. And we know that our population pyramid is very different in Africa, and we have a big proportion of young people. But these young people are affected with many other issues. And there is an incredible amount of HIV, there is an incredible amount of tuberculosis, there is an incredible amount of malaria, particularly in children. And malnutrition. So how is this virus, which behaves in a relatively benign way in healthy individuals, younger individuals, is going to behave in a setting like this? This is a question that needs a proper answer. And the third point, which is important, is to understand what is happening. We know that in many settings we are using antiretrovirals, we are using antimalarials to try to chemoprevent or to try to make the prognosis of the infection better and the clinical disease better. Many of our people are already under these kind of drugs. So can we document what is the incidence in these people which are already receiving antiprophylaxis, antiretrovirals for HIV or antimalarials? So this is important. And finally, I would like to finish by saying that we have a scarcity of health workers in our country, in a country like Mozambique and in many countries in Africa, and they are the real frontliners. There is no replacement for them. There we need to establish a very good protection of those frontline workers, because otherwise we are going to be left in a catastrophic situation. And without them, even though and understanding the fragility of the health system, we will have no chance of trying to fight back this epidemic.
Thank you, Kike, for this overall overview about the potential help of community surveys. Even it's maybe not the best moment from the point of view of governments, but it's always important to have the real picture of the data. It's always important, and thank you for pointing out these different researches about what is going on with the HIV people, with their treatments, and to see if it's possible to have some advantage having this treatment, and also talking about the scarcity of healthcare workers. We will link that later with Marta, and the potential of what can we do, what can be done in a country that people cannot stop working. I think it's a little bit the key of the issue. But we can keep now moving forward, and then we will discuss in a very rich conversation between all of you. But let's keep moving, and let's talk now with Ibrahim Ali Mohammed. Ibrahim, I met him years ago. He's a guy from Nigeria right now, living the lockdown of New York. So I think it's a good person to talk today about from a lockdown, and to see and to listen to him how he thinks that Nigeria will face this huge crisis. Thank you, Ibrahim.
Yes, thank you so much, Jordi, for the opportunity to be part of this platform and also to speak to your audience. I also like to thank the other panelists. I think a lot of what they've said is similar story of Nigeria. It's similar in the case that it's just that for Nigeria, there are significant issues around the complexity of a country and also the potential scale if the outbreak is not properly controlled. And what do I mean by some of these things I'm talking about? Nigeria, for some of us who might not know, is the largest country in Africa, one of the largest countries in the world. We have close to around 200 million people living in Nigeria. And it's also, although classified as one of the wealthiest countries in Africa, but that has to be put in context in the sense that it qualifies only as a low middle income country with around just $2,000 per capita in its GDP. And it's also a country that operates a federation system, which is quite similar to the US where I'm in. And I know how that can be chaotic in terms of the logistics of, coordinating an outbreak preparedness and also a response process. And given the backdrop, I still would want to talk about the fact that Nigeria has one of the highest burdens of infant mortality in the world. You have, it's around 62 per 1,000 live births. Every 1,000 live births, 62 infants don't make it to their first year of life. And for every woman who tries to deliver, in every case of 100,000 cases, 500 women die during or around delivery. And it is still a country that is having the challenges, as mentioned by a lot of our other colleagues, of maternal newborn diseases, nutritional diseases, and some of these, how they interact and might impact with the outbreak, we still do not know. The second greatest risk factor for diseases actually in Nigeria happens to be issues around unsafe water, sanitation, and hygiene. And you can understand within the context of the response how a country like that might want to respond. And within our health system, Nigeria scores a health access and quality index score of around 51.3%, meaning that there might not be enough systems resilience if we are to be in an uncontrolled outbreak. We've been talking about thresholds in countries like Spain. You can imagine in a country with 200 million people, what that might spell out. Now, to talk about the case, for Nigeria, Nigeria is getting into its fourth week of transmission of the case. And the case, as we are seeing now, has been increasing exponentially. During these past weeks, at least the number of reported confirmed cases, you have to keep in view the fact that these cases are confirmed, but we are also suffering from shortages of diagnostic materials. Have been 20 cases, jumping from around an average of between 7 and 8 cases. During this week, there have been a consistency of around a median of 20 cases. And the total number of cases that is around Nigeria is around 224 cases, as checked, I think, just early this morning. And there are 192 receiving care, 27 have recovered, 5 deaths recorded, which puts a case fatality rate of 2%. But significant for epidemiologists, we still do not understand issues around the attack rate, how it transmits, a lot of what I think Kiki has talked about. Our first case happened to be someone an Italian citizen who came in around the 25th of February, and he was diagnosed 2 days after. And that case has been account for close to a third of the cases that have been transmitting. However, the country itself has actually is moving gradually from the third, we believe, to the fourth stage, which we know might spell a lot of challenges for the health system. And a large amount of these cases that have been seen, close to about half of these cases, happen to be in Lagos. Lagos, as we know, is one of a state with around 20 million people, one of the largest urban densities, has one of the largest urban densities in the world. So what this spells for a country or the continent of Africa is something we still might just be imagining. So half of those cases come from there. The other happen to come from the administrative capital of Nigeria, which is a quarter of those cases are in Abuja. And it is what we've seen is that around 44% of these cases had travel histories around countries that are high risk in Europe, Asia, United States, and around 17% were actually direct contacts of people with a positive travel history. The country has not actually sat on its oars. They've been doing a lot to try to mitigate whatever will be the consequences of this. The country declared a level 3 activation of its emergency operations center, actually, 2 days after, a day after the diagnosis was made. And the model they've chosen had been to do lab testing of symptomatics, contact tracing, and also a social quarantine. The challenge has always been, of course, if you are doing lab testing of symptomatics, we already know how the issues might be with the amount of filtering that you would have to do, and the amount of cases that might be asymptomatic that are left undiagnosed. And in terms of contact tracing, of course, well, maybe even a bit better than what the US has done. The country has been able to trace 8,000 contacts, which they are continuously monitoring and following up with. But even within that, it's estimated that close to 1,500 are actually filtered out that are supposed to be traced, but the system has not been able to find them. And the country has also made some mobilization around making a fund of around $1.2 billion available for the COVID response. How, as laudable as this is, this spells a lot of challenges with regards to the other, I would say, health system challenges that are in a country that spends just around less than 3.5% of its total health expenditure, public health expenditure on health. The surveillance is ongoing in Nigeria, and similar to Sierra Leone, Nigeria has been able to catalytically, use the learnings it got from Ebola to be able to, at least in terms of molecular lab centers. As of January, the country had no capacity to actually diagnose confirmatorily the COVID virus, but within, I think, 1 month, they were able to set up labs, 7 labs across the country, and with a plan to set up 13 more labs. But you have to put that in the context of a population of 200 million people and how that might be. The labs have been running around an average of 1,500 cases in a day, but they are also suffering from the issues regarding these test kits and the fact that they're having a high turnover, and with that and the global supply chain challenges of getting media, of getting what they would need to, the materials they would need, the country might be running into a deep shortage with regard to that. We've had 5 deaths, as I mentioned, and many of these had comorbidities. But the issue with regards to how the system might respond in a humid country like Nigeria is still something that the government, of course, has not directed its attention to. The government is more looking towards how to do case management. So there's been little around research around how these have been evolving in Nigeria. And a last part I would want to mention, especially for our audiences who might be in Spain and in other places, is with regards to the human resource capacity for a country like Nigeria. It's still a bit better than many other African countries, but you still have that it's only 4 out of every 10,000 individuals we have as physicians, which is when you compare to Spain that has close to 40 per 10,000, and in a population of around 200 million, you understand the grave challenges that might lie ahead if the country does not take hold of what it has. I think we would discuss a lot of these things further as the panel expands. Thank you.
Thank you. Thank you, Ibrahim, for your capacity of speaking so quickly and give us so many different data. And it's been impressive, your summary. And thank you, because the vision it's a depth vision of the capacities of the country, and we will discuss that later. And you have exposed very well how a country of 200 million, even having more resources than the neighbors, could really face a big crisis. So we'll talk about that later. And finally, to explain about the situation of preparedness, of emergency preparedness in Zimbabwe, Juan Burgos, a global health specialist from Republic Dominica, but he's been working for many years in France and in some African countries. He will explain us a project going on in Zimbabwe to cope with the preparedness of the emergency. Thank you, Juan.
Thank you, Jordi, and thank you all the colleagues for the presentations. It's very, very interesting to hear what's happening somewhere like around in Africa, because this is a major concern. What's the future of the pandemic in this context? Knowing that the health system is not strong enough, as Marta said, knowing there are many other conditions, health conditions to take care of, as Kike and Eduardo said, so like malnutrition and HIV and tuberculosis and all of them. And the main aim in preparedness is to, first of all, provide care to those people in need in severe cases, but also be able to provide information and awareness to the population in order to prevent the overload of the health system. Because we know already from the European experience and from the Chinese experience too, that the vast majority of the cases do not need to go to the hospital to get care. So if we can prevent this whole fraction, this big fraction of the population to go there, and only foster the access to those severe cases. It will be a great help for the health system in Africa to start taking care about the cases. So that's the case of Zimbabwe. We started the Ministry of Health make a call of a consortium, bringing together the local private sector, the international NGOs, the local academia, and other private partners to create a platform, a triage platform using digital health to enable the population to call and start a first triage. What have been done in Europe already, but with technology adapted to African countries. We know from experience that telephones are spread all around in Africa, maybe not smartphone, but like the simple ones. We use it to transfer money and transfer other things. So people do have access. So the government, they create this free toll number where people can call. They can access to a trained personnel that help them to define their symptoms and classify them in terms of severity, and then help them to take the best decision to go to the hospital or to stay at home. And in case there is no symptoms compatible with the COVID, then just preventive messages. And this platform has been created under an open source program, which is available in the country, is sponsored by a local telephone operator too. And the idea is to reach as much people as we can before the epidemic spreads there. As I said before, first of all, to create awareness, second of all, to help people take the best decision, and third of all, and very importantly, help the system to provide the best care possible to the severe cases and to strengthen the information system of the country. We know by experience that, as we already said, the healthcare, specifically healthcare system in these countries is very weak. So if we can prevent them from the overload, from collapsing, it would be already a big first input. Then, of course, in the system, we're considering also connect hospitals and healthcare centers of all levels to know what the availability is, what the resources are, what the needs are, and be able to direct people calling to this contact center to the available places, preventing again to overcrowd certain points, knowing that the sizes of the cities and so are different. And this is summarizing the idea, but of course it's much more complex because technology in Africa is something emerging. It's working. It's not as many people think that there is nothing there. There is also already a lot of digital health platforms, but now this is a big challenge that digital health can be also part of the scene and bringing cost. Essential intensive solution at the low cost prices for the countries like in sub-Saharan Africa.
Thank you, Juan, for that vision of Zimbabwe and the preparedness of a country that still have very few cases. I think that the spirit, as you say, digital health. In the case of Africa, digital health has a great potential. And myself, I've been different times for example, in Nairobi, and there's a huge innovation hub where I can tell everybody that the innovation there has nothing to buy any other innovation hub around the world in terms of digital health. And Africans have the capacity of what we call to add different Legos very quickly, and in that they're really good. So in that sense, WHO hosted a 3-day hackathon 3 days ago, where they're trying to join all the forces from different African countries, and also they did a course of 500 healthcare workers around the continent joined in a seminar, in a webinar, where they were being taught how to treat patients, how to make the triage, preventive. So, but going back to just 2-3 big questions, and then let's start the debate because it's been super interesting. What Eduardo was saying, that there is no capacity to buy things, So what is needed is to enhance innovation, internal innovation, with the support of external innovation. Second, what Marta said, that it's impossible to stop the labor, no, the capacity of people of stop working. No, I mean, people need to work to get don't get disturbed. So and then what Kike said, no, it's important to have the data. And what you were saying, Juan and Ibrahim, no matter what the resources are, the countries are the population is very high. So we need to somehow to implement extreme measures. So in that sense, Eduardo starts with it, but then all the others, Marta, Kike, can start adding their ideas. Because, for example, what can be done, or what kind of innovation you need from outside? Marta, an app like the Korean app, where the people could be locked down in order with a QR, that would work in your countries? And Kike, how you can convince governments to be alert enough to have this data, you know, as the main light to take decisions, no? And Ibrahim, how you can really enhance your capacity with these laboratories, and how you can help maybe your neighbors, because you are the big brother there, no? And Juan, how you can convince the other countries that are not maybe preparing themselves so well as Zimbabwe with this preparedness? How can these countries get example? Open questions, and I give you the word. And please, after Eduardo starts answering the first question, keep answering or taking the word, and let's have this nice debate. Thank you, Eduardo.
Jordi, thank you very much. I mean, just with these interventions has been great. It has given me so many ideas. For example, Juan, I'm super interested on what the work that you guys are doing in Zimbabwe and the triage and the platform. So maybe we can have a conversation offline after this. I mean, I think like putting these different perspectives is great. Talking about technology and about this response, I think, and this is a general reflection maybe, that we are seeing a shift of the paradigm of how epidemics are responded in Africa. And I will explain myself. I mean, and Marta will remember for Ebola times that basically in Ebola at some moment, we had in the three main countries with the epidemic, in Sierra Leone, in Liberia, and Guinea, the support of the three former big colonial powers, the US, the UK, and France, supporting the former colonies. What we are seeing now is like any of the countries of the G20 are now, as a country, in the right position to support Africa as used to be in that case. So, I mean, all of us, we are very familiar with the cases of Spain and Italy, but as well, we are seeing the UK with the cases rocketing, the US, now with the country with most cases in the world. Maybe the first one that it's seeing the light is China, that maybe will emerge as the next power responding to epidemics. But to me, what is the difference here now is like we have like two approaches that are working. One is like the technological approach, like so what Singapore, South Korea are doing, like using technology, using apps, adding one T, that is technology. So basically, to control epidemics, you have always test, trace, and treat, right? Now we need to add maybe another T, like technology. This is like Juan is doing in Zimbabwe, that South Korea has been doing, and maybe what we need to do here. The second one is like, the second change in this paradigm is like, I mean, I guess Marta didn't mention it, but I guess her 20,000 tests are the tests donated by Alibaba Foundation, by Jack Ma, the richest man of Africa, that has donated 20,000 tests to all African countries, to 52 African countries, including Mozambique. I mean, we have in the country like 25,000 tests, and 20,000 came from him. I guess in Sierra Leone is the same. Bill Gates is going to start these vaccine production centers, like 7 of them to try to produce the new vaccine. So we cannot rely in the former ways of doing business. I'm talking even myself as UN. We used to have donors that we canalize the money. We go to the global markets with our strong supply chains. This is broken now. This is not functioning. This is severely disrupted. So we really need to think out of the box in this case. Sometimes I have the feeling that we are like watching a movie, like, you know, in a slow motion, We saw like China like falling apart like 3 months ago, and we didn't notice almost. Now we are seeing like Spain and Italy, how they fell, and how they are recovering, but in a slow motion, right? And now we are Africa's next, and this is very time sensitive. In Mozambique, in South Africa, as Kike was mentioning before, they moved from 1 case to more than 1,000 cases in only 2 weeks. Marta talked about the case of Guinea. Here we have only, 10 cases, but likely it's because we are underestimating our cases and we don't have capacity. About 20 tests are done every day, so we don't know the real situation. So I don't have the solutions yet, but I know that we need to find them very, very quickly. This is very time sensitive. I know that technology will help the innovators that are here in Mozambique, in other African countries, like communities of practice, talking to each other, like things like this one that Jordi you are doing, like trying to put brains from different backgrounds. All of this will help. And maybe something that is not in the question that you mentioned, but came to me when you guys were talking, is on this, that this goes beyond health. We are, all of us, we are medical doctors or we're working in health. But when you think in the lockdowns, in the economical damage, the financial damage that is going to happen in many African countries with the lockdowns, with the investments running away, with the global markets and stocks like drawing. So this is going to affect the life of people, and we don't know until what's going to happen next. Maybe we're going to find social unrest or violence, or maybe like, I don't know, change of government. So I think at some moment the waves of this epidemic can go very, very far away, and we don't know that yet. And as you see, Jordi, I have a lot of questions, but we don't have any solution yet.
No, but very good. Thank you, Eduardo, for your enthusiasm and putting more questions. Kike wanted to say something.
I raised my hand because I wanted to say something in addition to what Eduardo was saying, which is we have one single advantage, which is the direction of the epidemic. Normally and traditionally, we've been used to having outbreaks or epidemics starting in low-income countries or in Africa, and then slowly menacing to come to our settings. And here we have, it's the other way around. Things have started in China, of course, and then quickly went into Europe and into the US, and now it's the moment when they are arriving to Africa. So we need to benefit from this strange situation in the sense of bringing all the knowledge that we're able to generate in Western countries immediately to the poorest settings, while there is still time to do things. And then I have a second comment, which is in relation to, maybe it sounded when I proposed that it was important to do community service and understanding the true burden. This is not a gratuitous idea. This is not a superficial idea. I think not seeing cases doesn't mean that there are no cases, and that's my concern. And many African countries are very good at somehow concealing what is really happening under the excuse of being able to test poorly. And that's the tragedy, because we will not understand the magnitude of the problem until we really have a clear idea of what's going on at the community level. And you have to remember that in many African settings, access to the health system is really bad. The Mozambican government of Ministry of Health defines that access to the health system in the country is more than 60% of the population do not have access to the health system, which means that they live further away from 25 kilometers from any kind of health system. So there are many things occurring at the community level that are never seen by the health system. And that is why we need to get into the community and try to understand what is going on in order to understand what is really happening and what are the priorities.
Thank you, Kike. Marta, an app like the Korean app, or in a more relaxed way, of course, as you explained, it's so difficult to make people stay home, make people stay at home. But what do you think could be done? Because at least something must be done from the different experiences, and maybe taking a different approach.
I wanted to bring in that area 2 main points that for us, at least in Sierra Leone, have created a lot of controversies and a lot of discussions and setting up policies in the country that are a little bit different to what is going on in Europe and US and other countries, and mainly Asia. One is about this, the lockdowns, no? Like the lockdowns mean that prices increase, people don't make money. You also make people stay in a maybe more high risk environment than being even in the street, you know? Like most of the people, our population, 60 or 70% of our population are people that are living in poverty conditions, and most of the compounds and houses we are talking about 20 people living in the same house with no ventilation, sharing the same spaces. So one way sometimes of producing an increase of transmissions and infections is just putting everyone together in the house and not allowing them to move from the house. So, and this is where also the second point comes. But from this first point, I think that even so far, we have only declared like a lockdown for 3 days that starts today. The fuel has increased, the rice has increased, most of the basic needs in the markets, they just decided to duplicate the price. Everyone was asking and trying to get money, asking for money in their jobs, like advance of salary, etc. Because right now in the previous week to the lockdown, everything has already gone double price. And we are talking about very basic things. I'm talking about rice, I'm talking about water, I'm talking about oil, very, very basic things that people need to live. And second is, and this is the other part that I wanted to bring, because for me was a very important idea when we started working on the preparedness, was what do we do with mild cases? Like in Europe and US and also in Asia, it was very clear that mild cases don't have to go to ICUs. They don't even need to be admitted. Let's rely on our primary health. Let's keep people at home. But what type of homes are we talking about? Like most of our houses, nobody has a self-contained room with a toilet, with ventilation. If I ask one of our positive cases, even if they are house symptomatic, like only fever, only short throat or whatever, staying in the house, I'm infecting all the family. And then it's a completely different story. We don't have like a primary health, like a GP that can go to your house or talk to you on the phone, give you this medication, the other. Allowing people staying at home means that we are going to expand and duplicate and triplicate the cases in just one day. You know? So we had many conversations, and one of the policies of the government of Sierra Leone was that we were going to admit every positive case in treatment centers. But this is, as you all can imagine, right now, if you start calculating how many beds do we need, do we have beds enough to do that? No? So right now we are in the scenario for thinking about, okay, one treatment center for severe cases, but then we need to set up community centers or non-health facilities that they can have some kind of 2-3 nurses, community health workers to manage them, control them, etc. And then we have the third factor, because we all agreed only confirmed cases that are severe going to go to the treatment centers. We're going to set up social centers to keep the positives one to stop the transmission in the community. But then the third point is all our first cases are high class. Diplomats, rich people, diasporas, expats, people who, if you ask them to stay 1 week, 2 weeks, sleeping in a cholera bed in a church, they will never accept it. No? So now we're going to the second part about like, what are we going to do with these mild cases? Like we cannot keep them at home, but also these community centers that WHO and the rest of the technical advisors are recommending to create, they are very complicated in the moment that we are right now. And I think we are living this thing in many of the African countries. The first cases are coming from a certain social level that is very difficult to control. No, it's very difficult to put them in quarantine. It's very difficult to monitor them. It's very difficult to stop their movements and to tell them what to do, because they are the ones who are used to be having the power and the authority. I don't know, Ibrahim is just like doing, I would like to hear his opinion about that, because the thing is, what my conclusion is, the lockdown is very complex for the economical consequences. The second one is the approach in our societies in Africa about management of people at home, primary health, is very complex and can be even risky. And the third one is we have now a first bunch of first cases that are extremely, extremely difficult to control, because these people normally don't follow the same rules as the general population, and you cannot force them We are talking about ministers. We are talking about chief medical officers. We are talking about like a director of UN or UNICEF or a big NGO or even diplomats like happen in Ghana or in other places. No, it's very, very complicated to control those situations, and we cannot use the same patterns as we have done in Europe and US.
Yeah. Hello. Yes.
Go ahead, Ibrahim.
Yes. So I was nodding. I was vigorously nodding to Marta in the sense that that was the scene Nigeria just a couple of weeks ago. So, and it brings to the question that you were asking, like, how can countries help? I think a lot of what we've seen is that the context within Africa might be unique to Africa, and there's a lot that we could gain a benefit in terms of even knowledge sharing, like we've said, and in terms of the model of response we choose. The context for response in Africa might need to differ, especially as we've heard a lot of the other panelists have said. It's funny, but a large part of the class of people who were actually firstly affected were from a certain strata, which were the upper echelons of society who have the ability to travel. Like I'm telling you, Lagos and Abuja, they are also the states with some of the highest GDPs in terms of the country. And we've even had issues like governors, ministers being infected, and what challenges that Nigeria had to contend with in terms of responding to that are very, very crucial things that can be shared with other countries. And a large part of what I've seen around, especially, we've talked about, yes, North-South collaboration, very important, but I think more crucial is the shift to a South-South collaboration within countries. We know countries are trying to respond to within this context. So there's still a lot of, it's a storm in the air. So most countries are thinking within their nation, what can I do? Am I even sure I've finished what I'm doing? That instinct is very, very strong. However, we know that public health does not respect borders, and knowledge itself, for us to be able to build some sort of systems resilience, we need to share the information we have. So Nigeria as a country can definitely would benefit itself and also other countries around it, like Sierra Leone, if there was a repository of or a sort of coordination process whereby knowledge around how their responses and the challenges of responding to some of the unanticipated events they have is being shared. This, of course, we know that WHO is doing a lot but that's just literally just a case list that is done and response, which doesn't really talk about the context challenges that we're facing. And I think that would be a very, very crucial value, which I think countries should start thinking about. We've also seen that there's been a failure in terms of coordinated leadership. Countries have started. Ethiopia tried, they've been linking with South Africa, to see how they can coordinate the response in terms of largely getting in funds and maybe some sort of negotiation for supplies. But it's not been a sort of all of Africa response to that. And that itself might cause some sort of inefficiencies. Nigeria as a country had a lot of technical capacity, maybe based on like it's a large country, you might find that there are many people who have, they has some sort of good human resource capacity compared to many other African countries. But the challenge it will suffer from, it's not only about a finance challenge, but also about the challenge of not being able to coordinate with other African countries to expand the economies of scale with regards to what will be crucial and what is vital. Some of the things we're talking about now, in terms of ventilators not being available, in terms of bed capacity, isolation unit, knowledge transfer on a South-South level, in terms of how countries are doing all of these things. If there's a pooling of such resources, not just Nigeria alone, but I'm talking about the global South, especially within Africa, I think that would go a long way to help. I see Ethiopia started, they started communicating with Rwanda and South Africa, but largely missing there was Nigeria. And that would not help in getting the kind of response that we're trying to push forward. A very, very important thing I also would want to talk about is that we all need to situate this within within the context of the resilience. We know new and emerging diseases they will be re-emerging. This happened 2014. We had a pandemic, Ebola. 4, 5, 6 years now we're having this. We had to anticipate that. Well, we know if the world does not end, we're still expecting that you might be having some of these emerging diseases. How ready is Africa, to contend with these issues? funds alone that are given, as a response fund, UN has been able to mobilize around 2 billion. Nigeria domestically was able to mobilize 1.2 billion. But the challenges, as Marta is saying, is that where you don't have a strengthened system, piling all of this within, a short limited period of time, large amount of money might not necessarily go well. So as a country or as a continent, I would say we need to start thinking about some of those robust mechanisms, and also thinking about, we've said, knowledge transfer, implementation science that are context relevant to Africa. And also now that we are having almost a paralysis in terms of medical supplies from places like India and also China, countries like Africa suffer a double burden because there's almost little to no non-existent local medical technologies or domestic markets within almost all the countries of Africa, apart from maybe South Africa, which itself is not able to satisfy its own domestic capacity, not to talk of other countries. So I'm saying this is an opportunity for countries who are serious to really refocus the paradigm of how it sees itself. It's also an opportunity for solidarity to be built within the system in terms of how we transfer our knowledge and how we build upon better efficiencies for a more robust system, across Africa. And of course, North-South collaboration is always welcome. Everybody knows this is important. Countries ahead of the curve might be able to supply us with maybe their learnings, the technologies that they have that's not already, that they might not need, so to speak. But what those countries will tell you is that they're afraid of a second resurgence. So in a way, we still have to come back to what do we do now that we're within this system, knowing that even if we scale this and we come out of it, some other case might actually come up in the future. And it's an open question. So, but these are just my own thoughts about how, we have to start seeing these things going forward.
Thank you, Ibrahim. Obviously, what you mentioned about South-South cooperation could be understood initially as African cooperation. No, I think that President Ramaphosa of South Africa started this weekend a very aggressive campaign of testing in many places, and they could have some capacity that could be shared with other countries, and also internationally innovation, as Eduardo said. No, there are many innovators that have done many things that could be emulated and even improved. No, in Africa, respirators. They're not really mechanical invasive respirators, but they're Ambu respirators, which the maker community of Africa maybe could really take advantage of their ability. Maybe Medtronic said publicly yesterday that they are opening the patent of the respirator. Maybe a consortium of Africans could take advantage of that moment and start building the respirators themselves. No? So Juan, or any other, how do you see this? Because this is a young population. Africa has a younger population than the rest. Maybe the mortality rate at the end will not be so high as other European countries because they have older population. If Africans start to see that as an opportunity, do you see Africa better in 3-4 years, or the moment it's so great that the failure of the system will make that not possible?
Well, for me, may I answer?
Yes.
Because I have like 2 lines. I was really, first of all, I was really touched by what Marta said, and it's very true that the mild cases, what I'm going to do with them. But there is an element here that we should consider, and I don't see them in any guidelines yet, like adapted to Africa, is the social structure of communities in Africa. You have, like, in our project, we stated clearly, the linkage is done with the community, and the community have a chief, and they all find solutions always adapted to the context. And I've seen it before. It's maybe not always appropriate in terms of practicality, but we can help them to make them so. So this is an element that we should consider there, because of course there are different levels of people. People who are not gonna stay in the cholera beds, or other ones, some other standards. But in the community, at the community level, they might find a solution for the community people. And that's one thing that I haven't seen yet in any guideline. In Africa, it's very communitary. And if you don't go through this structure first before implementing anything, things are not really sustainable. And second of all, I think we should think about this not only as an emergency preparedness for COVID-19, but for any other emergency in the future, because it's something that should be cross-sectional. We can just adapt every time. And the place of technology, as Eduardo said, is key here, because I also believe, as I see guidelines, African continent and African resources and capacities are really underestimated. And we are still counting, like tolling points. Whereas we have a generation of people, trained people working already. I've seen it myself, because just before Zimbabwe, I worked in Mozambique with technology too, developing apps. I lived there for a year and a half, and I worked with the Catholic University of Mozambique. And we developed apps for improve the management of HIV people there. And they are motivated, they are young people, motivated, looking for opportunities to develop more things. So if we put all these three things together, first of all, considering from another perspective, African capacity, local capacity, considering also the social structure of African communities, and third of all, putting this emergency preparedness as a cross-sectional issue, maybe we can find an argument strong enough to build something more sustainable. Because it's not only responding to this current emergency, but it's also building a stronger health system, which is also have to see with this preparedness. And as you said, like the pyramid is completely different there. There are much more younger people there, so probably the mortality rates and so will be different than in Europe. But we can create awareness not only about the severe cases, but how to prevent COVID and COVID-like things too.
Eduardo, Marta, Kike, do you want to add something? Thank you, Han, for this summary.
I completely agree, and I think that right now one of the lessons that we got from Ebola, at least in West Africa and Liberia, Sierra Leone, and Guinea, is that we have not been able to strengthen the healthcare system through that crisis. And I think that is one of the things that none of us is going to be able to forgive ourselves, in terms of there were like a lot of setting up treatment centers, bringing a lot of money, a lot of funding, support, etc. And we have not been able to set up anything sustainable after that. It's true that IPC, at least in countries like Sierra Leone, Liberia, and Guinea, infection prevention control now is something that is extremely prevalent and people are very aware. You work in the hospitals and you see that the washing of the hands, the use of gloves, the way to protect themselves with the patients and everything has improved a lot. But we didn't use any of that money from Ebola to build like a new hospital, to set up certain systems of referral for healthcare services. And this is one of the things that I love when Ibrahim was saying it, because this is exactly the point that we all need to remember. It's like, this is another one that is coming, but tomorrow is going to be another one. You know, like for us, coronavirus, yeah, it's bad, but Ebola had like a mortality of 60% of people. But Nigeria, Sierra Leone, Liberia, we have everyday outbreaks of Lassa. Lassa that is also killing 20, 30% of people. You know? And Lassa is not as infectious as coronavirus, but could be as infectious as Ebola. And in one community can definitely affect many people, you know, at the same time with a mortality that is definitely higher than coronavirus. So is this one, but tomorrow is going to be another one. Now we have an outbreak of measles in the north of the country, and probably 10% of these children are going to die of measles. So we are dealing with this in a daily basis, and we keep on going after the problem instead of like we are not able to anticipate to create some kind of protection. I think that the best example for us, at least, is Nigeria. I know that nothing is perfect, but Nigeria has a public health service, and for these kind of things that is extremely developed. They are working really hard. They have been able to control the latest outbreaks that happened. And even now with the coronavirus, they are being very exemplary in the way that they do it. But definitely there is something that we're doing wrong that other countries have been able to do right. Like, look at the example of Rwanda, how they use the funds after the genocide to try to reconstruct a society, creating a system. If some countries have that kind of example and they show that they could do it, why don't we just also use our resources now that may be able to come to also start creating more consistent and solid structures? Because otherwise we're going to be, every year is going to be one new thing. For Europe, this is new, but for us in Africa, this is not new. Every year you have one big crisis, no? So I don't have a solution, but I really think that a lot of people, that a lot of money that comes inside of the country goes to just like fill gaps instead of setting some kind of standards in a general sustainable way.
So Jordi, just so if I can now, from my side as well, like trying to have a positive note. I mean, this is really, I mean, we like the ones that now we're in Africa, we are working 24/7 for the last few weeks. This could be very overwhelming, or scary. We don't know what's going to happen. But, you know, like listening to you guys and the ideas, the thoughts, the analysis that Ibrahim, that Marta, that Kike, that all of us were doing. And I don't know, I'm feeling more optimistic now. So maybe it's wishful thinking. Maybe. But really, I think this is the kind of things that we need to move, right? It's like to be talking, to be getting the learning that others are doing. Kike said that very well. I mean, people are, or Marta now, we have been going through this in the past. At the end, this is a basic epidemics with a twist of technology, and we can beat this. And I don't know, maybe but I'm feeling better, to be honest. It's going to be a nice end of my Sunday. Yeah. So that's my remark.
Thank you, Eduardo, for your positive remarks always. No, I was thinking because IS Global, no, did a wonderful job in Mozambique during many years, no, and Maputo Manisa Center, it's a consequence of that, no, and there is a transference of technology and so on. But basically, after 40 years after Alma-Ata with primary care, no, primary care was already thought there, no, and in the countries that primary care is not working, what Marta was saying before, no, after a big crisis, we are not able to leverage all what we have, all the money, and maybe it would be a good reason, no? I don't know, what do you think, Kike, of rethinking again the importance of primary care in every single system, and how that, as the Rwanda case, added with the new technologies, can really be a boom, no, a boost to improve systems. What do you think, Kike?
Well, yeah, I don't think we have abandoned that vision, and WHO is very conscious of that, and at the moment is again pushing for universal healthcare, primary healthcare. So I think we are on the right path, even though we are progressing at a very, very slow speed. Perhaps this crisis and the consequences of this crisis are going to be useful to reconsider the importance of primary healthcare to access to care, which at the moment is a luxury to many African countries, and I think research can help in a way with a longer term vision on how to multiply the impact of some of the actions that you do. And I don't think I have much more to add. I think Marta and Eduardo have very beautifully and very eloquently mentioned. This is the routine for Africa, unfortunately. So we will survive this in the same way we have survived previous ones. We will come out of it, maybe not as strong as we were, and I hope we don't go back to a level of development that we were seeing many years ago, and we can keep as we are and not get too bad. But we will go on, and because we will go on, we will be able to plan things better and learn from this, and hope that the next one that comes to us, we can deal with it better.
Thank you very much. Thank you, Eduardo, for your work these days. I know that you are calling everyone in the world that you know to bring innovation in Mozambique, and also I suppose you will export innovation soon, because Mozambicans are very good in that also. Thank you, Marta, for working hard again in that new crisis. No, we know you're working very hard in that, and we hope it will not be so grave as the Ebola, but we can learn from that. Thank you, Ibrahim, for being open to collaborate in that talk from New York. And thank you for all your vision from Nigeria and the possibilities. Thank you, Juan, for your explanations and for your work in Zimbabwe and Mozambique before. And we know you are working now. And welcome to Barcelona. We know that Juan now has come to Barcelona. And thank you very much, Kike, for the work that DS Global and yourself is doing in research and continuously and always trying to raise the bar of research to finally, people must remember that research is super important for this crisis, no? And after all this crisis, all these people that really applaud the system and the healthcare workers, that's why we start always the program like that, they must remember that they should try to vote for governments, or they should try to vote who really spend in research in healthcare. This is something I think is important. And I think because the governments have the word to choose when 5 years before one of these crises happens, how it will be the outcome of all that, no?
And this is going to be easier now, I think, transmitting this message.
Yeah, thank you very much. Thank you very much, Kike. And if any of you want to say a final word, please go ahead.
I just wanted to say one thing that I think it's been very, very interesting and also even a little bit overwhelming hearing from many of my colleagues in Europe and in the US right now about how much they understand what we went through during Ebola and during other epidemics, no? And I think I don't think that anyone needs to go through a bad time, but I think that sometimes from bad moments we can get good things. And I hope that also this bad moment to all of us in a global perspective help us to understand that sometimes this kind of health crisis can affect anyone, and we all need to be together and help each other, no? Like, and mainly when you see your brother that probably is going through more limitations than you, and you are already struggling, so just give a hand. And I'm really proud of seeing how people are becoming extremely empathic. And you know, like most of my colleagues that are right now front lines in Spain working in coronavirus, when they finish the day, they text me about like, how are you in Sierra Leone? I'm thinking every day, like, how bad could be in Sierra Leone, and look at us and look what can happen. And that makes I think it makes a click in the mind of people. No, I hope that this makes all the world getting together in understanding that we are together on this, and it's not north and south anymore.
Yeah. May I add
Can I add? Okay.
Yes.
Okay, sorry. Sorry, Juan.
No, go ahead.
Great. I just want to echo a lot of what Marta said, and that's largely coming from somebody who is an African and is ensconced in New York. And when New York became the epicenter of the crisis, it's very, very, it's a surreal feeling when you have people from Africa calling you to say, I hope you're fine in that place that has, and then, it puts to perspective, that common humanity that we all share, when it comes to some of these things. There are some of these shared experiences, and the hope that we have is that, some of these things, the forces that would unite us will be stronger than the forces that divides us. And the sense that we need in terms of human solidarity, particularly for what challenges us in terms of our health, also in terms of the ecosystem when we talk about issues around the climate, and also the global economy, and also governance systems like Kiki said, who support the common humanity and not those who feel like, some other things around capital are more important than human life and dignity. I just wanted to put that out there. And I wanted to thank everyone this was a fantastic session for me, and I'm glad to be a part of it. Thank you.
Thank you. Juan, final word.
Well, it's similar to what Marta and Ibrahim said already, because now I'm here in Europe, back in Europe since like 2 months ago. And I remember when I was there, still my friends from Europe called me because I lived the hurricanes in Mozambique. I lived the Ebola crisis in West Africa. And they all call me every time to know how it was. And now I got all my former colleagues from Africa, from Uganda, from Mozambique, from Ivory Coast, from Senegal, calling me, how is it going in Europe? I had myself already the COVID too, the first week. And I was in bed, like, what's a mild case, just fever and cough and so. And they were really worried. They're calling like every day, like, how are you doing? And this is it. I mean, this is solidarity. And this is how it works, actually, making it possible. Online or offline, making it possible. This is it. With ideas or actions, all welcome.
Thank you, Juan. Thank you, every one of you. And as Marta said, and everybody said before, let's work together to get some good results of all this crisis. And thank you very much. That was all for today. EPIDEMIXS TV, the first international chapter. We're looking for a new chapter soon. And thank you very much for being with us. Goodbye.
Bye. Thank you.